Hi, Dr. Anker.
Hello.
Welcome to JACC and the ESC meeting, and we'll just start by introducing you. Tell us about yourself.
Thank you so much for having me today. So I'm joining here today from the Charité in Berlin. I'm working there at the Charité Campus Benjamin Franklin in the Department of Cardiology as a clinician scientist. And we're trying to do as much research as possible. And here we had the chance to do actually meta-analysis of the 3 big randomized trials, controlled trials that have been done in heart failure and functional mitral regurgitation. So today we saw the RESHAPE HF2 data, which is very promising for this M-tier therapy in heart failure patients in the future. And that was very interesting to see. And we had the privilege in our team to already look at the data before it was published. So could we do a meta-analysis actually of the 3 existing trials? Meaning, so we looked at the COAPT trial, the Mitra-FR trial, and the RESHAPE HF2 trial. And we looked at the 5 endpoints that were reported in all 5 trials and looked whether there's common ground. So we looked at the 5 endpoints actually, and that were simultaneously reported, and that was hospitalization for heart failure at 24 months. That was composite of death and all heart failure hospitalizations at 24 months, as well as change in 6-minute walk distance at 12 months. As well as the 2 outcomes regarding death, so cardiovascular death at 24 months and death from any cause at 24 months.
Okay. So I think what we can say is we know that the COAPT trial showed reduction in mortality and heart failure hospitalization and improvement in quality of life. The Mitra-FR did not show any of those. So these were 2 discordant trials. So in a way, RESHAPE Heart Failure 2 is a tiebreaker and shows improvement in heart failure hospitalization and quality of life, but no impact on mortality. So your meta-analysis is essentially, and we should point out it's not an individual patient level meta-analysis, but a study level meta-analysis that shows essentially that there is overall benefit in heart failure hospitalization and improvement in quality of life outcomes.
Sure.
But in fact, we're not seeing improvement in mortality. We do see the improvement in the combined endpoint of mortality and heart failure hospitalization. And some people might argue that's being driven by heart failure hospitalization. So what are some of the key takeaways from your meta-analysis, and what are some limitations that you think should be addressed in future individual patient-level meta-analysis?
Absolutely. So well, first of all, when we try to understand this data, and you already mentioned a point that's very important, we do need an individual patient-level meta-analysis as soon as that's possible to do by the investigators, because we are seeing in all 3 trials very different cohorts that were actually looked at. So for the COAPT trial, we had a effective regurgitation orifice area of 0.4 centimeters squared, while it was in the Mitra-FR, it was 0.31, and in the RESHAPE trial, it was actually 0.25. So we're seeing very different levels of mitral regurgitation, and meaning so we better have to understand now which patients we could help. Because interesting, those 2 trials that worked, there was in the 2 outliers of the EROA. So it's going to be very interesting to see which patients actually benefited the most. And then secondly, what we did here in the meta-analysis, we used, due to the large heterogeneity of the trials, was around 50 to 80%, depending on the outcomes. We used the Der Simonen late model to calculate the results. And what we saw here, as you already mentioned, for the first 3 mentioned endpoints, there were significant results for cardiovascular death and all-cause mortality. We did not see a significant effect with the first model. So there's different thoughts on this,
Right.
which method is the best and the most good to use. We thought it's fairest and most best to show that there's different methods, and depending on the methods, the roles may vary actually. Coming back to the point that we now need the individual patient data meta-analysis actually.
Great. So I think it is fair to say that some people will take away from this that it in fact is a tiebreaker and has moved the statistical significance to be positive for at least heart failure hospitalization and quality of life outcomes Other people might argue that, you know what, if you look at this other statistical test, and maybe not. But what's important is that we have the data in front of us, and we're all going to incorporate this in our practice one way or the other. And I agree that individual patient level meta-analysis is what will really collect all of this for us. Another important trial that came out actually in this session was the Matterhorn trial, which is randomizing transcatheter edge-to-edge repair to surgery in secondary MR. And I think another addition to the meta-analysis will be the arm of patients who got TEER. Regardless, this was great, and I hope you get to enjoy the rest of your meeting.
Thank you so much for having me today.
Of course, my pleasure. Thanks.